We're gonna get started.
Hello, good evening. Thank you. As many of you know, but for those online, my name is Emily Baker, and I work here at Hope College as a health professions advisor. I want to welcome you on behalf of Hope College this evening. We at Hope are grateful for this opportunity to come together as a community to discuss a topic that affects all of us in some way. The Your Health Lecture Series is a unique educational partnership between Hope College and Michigan State University College of Human Medicine that has existed since 2016. The goal of this series is to feature physicians and researchers who can speak on a wide variety of topics of interest to public audiences. We appreciate your attendance here this evening and look forward to learning more with you about disparities in healthcare from Dr. Lisa Lowery. I would now like to introduce you to Mark Breevy, Director of Community and Government Relations with Michigan State University College of Human Medicine, whose partnership made this evening possible for us to learn.
Thanks, Emily, and thank you all for coming out. I really want to say a big thank you to Dr. Lowery. Dr. Lowery drove in from Grand Rapids. Kim and I drove in from Grand Rapids too, and the roads were not great, but you know what? We had to go virtual for this talk last year, and we decided we couldn't let down our Hope friends for a second year in a row. So like Emily said, my name is Mark Breevy, Director of Community and Government Relations at MSU College of Human Medicine. We've been collaborating with Hope College for about 9 years with this particular Your Health Lecture Series as a part of our two schools collaboration on early assurance program. I want to thank Emily and Hope College for the continuing partnership. And I would like to note that at the conclusion of Dr. Lowery's presentation, she will answer questions from the audience and those written into the Q&A feature online for as long as time allows. And with that, I would like to introduce our speaker this evening. Dr. Lisa Lowery is the Assistant Dean for Inclusive Learning Environment at Michigan State University College of Human Medicine. She is a native of Grand Rapids and a graduate of Ottawa Hills High School. She received her Bachelor of Science degree in microbiology with honors from Michigan State University. And then she went on to University of Michigan Medical School, where she received her medical degree. She completed a combined internal medicine and pediatric residency program at Spectrum Health Butterworth, Michigan State University Grand Rapids campus. And then Dr. Lowery completed a subspecialty fellowship in adolescent medicine at Johns Hopkins University. Dr. Lowery is an adolescent medicine specialist at Helen DeVos Children's Hospital, Corewell Health Medical Group. She has been faculty since July of 2004, and Dr. Lowery also serves as adolescent medicine section chief, division chief of Helen DeVos Children's Hospital Pediatric Specialties, and associate program director for the combined internal medicine program for the Michigan State University Grand Rapids campus. She's an associate professor in the Department of Pediatrics and Human Development. I could go on and on. She's very involved in Grand Rapids and a number of boards and commissions and all kinds of groups, but I will just go ahead and introduce Dr. Lowery.
Thank you. Thank you. My pleasure. And thank you for those of you who came out. This is exciting. I mean, I'm going to get all mic'd up because I have to get mic'd up for the online presence. But to be in a full room on a beautiful Michigan night, I thank you. Give yourselves a round of applause for being here. So we are going to have a nice discussion, hopefully talking about health disparities, disparities in healthcare beyond the exam room. I do have some disclosures. I am a Nexplanon trainer. Nexplanon is a contraceptive, and I train residents and medical students or residents and faculty how to insert them. I don't make enough money to be in Aruba or anything. Otherwise, I would not be here with y'all tonight. I would be in Aruba. And we are going to, for objectives, the importance of equity in healthcare, what causes health disparities, the impact of structural inequities in health outcomes, on health outcomes. So about a week ago, just a little over a week ago, and it was actually, I was at our Grand Rapids Urban League, or Urban League of West Michigan, I should say, our breakfast. And if I can count on anything, MLK Day, Urban League of West Michigan, we always have bad weather, and it did not disappoint and was weather like today. But I wanted to say that you cannot talk about, just because we are just a little over a week out. I wanted to share this quote, since we're also talking about health disparities. Martin Luther King, this quote, and sad to say it's over 60 years old, but still reigns true. And it says, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And now let me preface with, Mark didn't say, I've been practicing, I've had the privilege of practicing now for over 20 years. For some students who I met with earlier at the dinner, I take care of teenagers and young adults, which is fascinating because you never have a dull moment. And some people say, why would you take care of teenagers and young adults? But it is an honor and privilege. And I will say, I am in the field of medicine. And despite what people talk about medicine, and there are some struggles, and we're going to talk about the struggles today, as I sit here over 20 years in the game, it is still great to practice medicine. It is still an honor and a privilege to be involved in people's lives. And you have to consider a privilege, because there are very few, and I'm going to, a side note, there are very few professions where I strip you naked and say, "Ooh, please tell me about the most intimate details of your life," right? Right? And most of you are here because y'all want to go into medicine, right? Okay, so this is a side note. I was raised Baptist, and so y'all can talk back at me, right? Okay, it's okay. It's okay. I know. So those of the few of you who met me earlier, I was like, we're not going to be all stoic today. So, but why are we talking about this? Is because there's social determinants of health. And these social determinants of health are these non-medical factors in environments where they live, where they breathe, where they're born, where they operate. And the problem is, and you've all probably heard about these things, there's education, quality education. We have healthcare. We have neighborhoods where you live, where you breathe, where you act. You have this community context. Who do you hang out with? Is it safe? And then you have economic stability. Why do you, a living wage? I had this conversation with my students, with my learners today, my residents, and we were talking about, I said, well, this patient probably won't show. And they said, why? I said, well, transportation is a big deal for them. And we talked about transportation because they have they're a single parent, 5 kids, and they have to travel about 50 miles to get to me. And I'll be honest, as great as I think I am, the roads were bad. I wouldn't come travel an hour and a half to come see me today myself. All right. But these social determinants of health, and I like this one because it also talks about food, draws foods out here. All of these things, the income, the housing, the literacy, health literacy is another big passion of mine, this community engagement, healthcare, and this is quality. And we could talk each one of these about quality education, quality healthcare. All these things impact our health outcomes. So we know if we have quality of these things, this impacts morbidity, mortality, how long you live, how you function, right? But the sad part about this is in healthcare, by the time they get to our doors, whether you're going to be emergency room physician, orthopedist, ophthalmologist, adolescent room medicine physician, healthcare, quality healthcare, we impact about 20% of that. So all these social determinants of health, all these things, the physical environment, let's talk about clean air, maybe lead. We'll talk a little bit about that later. And then we all go to our doctors. We as doctors or healthcare providers, we tell you, don't smoke, don't vape, exercise, do all those things. Don't drink a lot. And, if you're sexually active, use condoms, those things. We tell you do all those things. We impact about 20 to 30% of that, right? And so that's what become overwhelming about this. Because you're like, well, that's why I don't have any impact on the person being able to get a ride to the office. I don't impact their coverage, right? And that becomes very overwhelming, right? And I will say this because I'm gonna, you might feel like, oh my gosh, here she goes. She's gonna try to make us feel bad. I'm not gonna try to make you feel bad. But I will say, as much as I love medicine, as much as I love healthcare, we got to do better. And I think we know grass is green, right? This is when the call and response, you're supposed to say yes. Grass is green, right? And then the audience says, sky is blue, right? Do we have to do better in healthcare? All right, I think y'all got it. Okay, So why are we here today? Health disparities and health care disparities. Let's do this kind of level set. Healthcare and healthcare disparities refer to differences in healthcare and healthcare between groups. A health disparity refers to a higher burden of illness, injury, disability, or mortality experienced by a group relative to one another. A healthcare disparity refers to differences between groups, such as healthcare coverage, access to, use of, and quality of care. Healthcare and healthcare disparities often refer to differences that are not explained by variations in health needs, patients' preferences, or treatment recommendations, and are closely linked to social, economic, and or environmental disadvantage. The terms health inequity and inequity are often used to refer to these disparities. These are some of the 2030 framework, but the goal that I want to draw your attention to is what we're here to talk about today: to eliminate health disparities, achieve health equity, and attain health literacy to improve health and well-being of all. Let me make it plain to you. I have two patients. I got Sean and I have Pat, right? Sean and Pat both have, I'm gonna make it relevant to patients I see. Both of them have eating disorders, right? Both of them live in Ottawa County, right? They come to my office. Both of them need to be admitted to a higher level of care. Let's make it relevant. I'll make it really plain for y'all. They both need to be admitted to Pine Rest Partial Health, PHP, Partial Hospitalization Program. Sean and Pat, you with me so far? If you with me, say yes. Okay. Sean's family, they have Medicaid. They're a working family, but for whatever reason, they have Medicaid. Pat's family have your name whatever HMO, third-party insurance, Aetna, Blue Cross Blue Shield, Priority Health, right? So I'm making it plain for you. If you with me, still with me, say yes. If Dr. Lowery needs to admit Sean, I have to get Sean's admission certified by Ottawa County's Community Health Program. If I need to get Pat admitted, I can just get labs, call it Pine Rest. And there's a chance that Ottawa County CMH might approve that admission. Is that equitable? Making it plain. All right. Okay. Kamara Jones, health equity is defined by this assurance of a condition of optimal health for all people. This differs from the Healthy People 2020 definition that says health equity is the attainment of the highest level of health for all people. Jones agreed that this is the ultimate goal, but argued that health equity should be seen as a process rather than a final outcome. So this is a process that we're going to have to do, right? And why is this so hard? Because it's multifactorial. But we know that health inequity, which is the uneven distribution of social and economic resources that impacts one's health. So we have inequities that lead to disparities that lead to poor health outcomes. Health equity is most often defined by the absence of inequities and disparities. This definition by Margaret Whitehead stated, health inequities or disparities are differences in health outcomes of specific populations that are systemic, pattern, unjust, unfair, and actionable, as opposed to random or caused by those who become ill. So Sean and Pat, is it their fault that they have two different insurances? Now, some of you could say, yeah, well, if Sean's family had a better paying job, then maybe they wouldn't have Medicaid. Let's be honest, right? Because I know that's how people think. But I didn't tell you why Sean's family had Medicaid. I don't know. I have my reason to tell you. But if we had, and I'm not going to get political here, but I probably might, if we had a system that was probably more equitable, then it wouldn't be a big issue, right? Okay, that's why we're here. Okay, so when we talk about disparities versus inequities, disparities are differences, person-centered, downstream. Inequities are just unfairness, systems, structures, upstream. And the reason I'm going to keep this downstream, upstream in your head, because I'm going to show you a slide later on and to talk about how we want to impact, how we're going to impact it, okay? These downstream versus upstream. And what we're going to do is we're going to talk about it from both ends. Now, this is one thing we used to do. In medicine, now let me be totally transparent. When I graduated from medical school, probably over 25 years ago, don't do the math, try to figure out how old I am. We didn't talk about this, right? We just now, over probably the past 5 to 10 years, started really talking to our medical students and residents about this, because young people such as yourself says, I want to go out and change the world, and I need to be able to interact with my patients. And I need to know the tools. And so even at Michigan State, we've implemented more things where we talk about things like structural competency and things like that, because I need to know when I need to treat my patients who have high blood pressure, and they come into my office and they haven't taken their blood pressure medicine. I'm like, oh my gosh, you haven't started your blood pressure medicine, you're just a bad patient. And versus calling them non-compliant, which we love to do, right? I need to know why they didn't take their blood pressure medicine, right? Is it because they didn't know why to take the blood pressure medicine? They couldn't get to the pharmacy. There's a lot of whys behind that. So we cannot have, and thank you for the water. Thank you, team, for the water. Whenever time you do one of these talks, you got to show this little, you show this fence slide. I mean, it's like, I think we can't pass if we don't show these fence slides, right? It's one thing we all have to do. So equity and equality. And I show this slide because if we really want to do equity, my husband is about 6'1", 6'2". So for those of you who are online, I'm about 5 feet tall. Okay. So if my husband and I, if we're standing at this fence, you give me a box, him a box, I'm still not going to be able to see over the fence. And then a lot of times I show this, and there's the person in the middle who's standing on 2 boxes. And I always wonder, if I'm that person, how am I going to get up on those 2 boxes? It's like me getting on one of those high top stools. It's not really cute, but it's till I get up there, but it's not cute getting up and down those things, right? But if we're going to be equitable, we're really, how do we, we want to make sure, it's equitable. We make sure everybody's able to get up and look around, and then we make it barrier free. I'm going to share this with you. About 5 years ago, there's a professor at Michigan State College of Human Medicine who studies Alzheimer's, Dr. Irving Vega. He was doing a talk on health disparities. And to this day, that still blew my mind. He was talking, he showed this slide he was talking about this. And he said, you know what? We always talk about the slide and we talk about removing the barriers. And yes, we should always be about removing the barriers. But do we ever ask these people, why aren't they sitting in the bleachers? Do we ever work? It's great to remove the barriers, but do we ever ask them, why aren't y'all sitting in the seats? Can they sit in the seats? And I was doing a talk a few years ago, and one of my colleagues' son heard me, and he said, Ma, but ask Dr. Lisa, maybe those people want to sit in the seats. Maybe these are VIP seats, but we never know. And if we're realistic, a lot of times we don't ask why these people aren't sitting in the seats, because that may mean we have to give up the seats, right? In our society, we're worried about who's sitting in the seats. Do I have to give up my seats? How much is it going to cost to build more seats? All these things. So I think when we're really talking about equity, we have to remember, not only do we need to worry about removing the barrier, but we also have to worry about, why are these people not in the seats? All right. Then the other thing we talk about is okay, you know what? But it's great. We have a great, and yes, America, great. Love America. Every time I travel abroad and come back, when I land, I'm like, oh, yes, I'm here. Thank you. And we talk about, we have a lot of access to things. We have a lot of access, but our access is not the same, right? My access is different, might be different to your access. Everybody's ladder is different. And then what if I have a ladder and I don't even know how to climb the ladder? Maybe I'm differently able. My ladder is broken, but I'm neurodiverse. I don't know how to climb a ladder, or I've never been given a ladder before, or I need some help getting up the ladder. So sometimes we're so focused on in society, well, you got a ladder. Do I need help getting up the ladder? Is my ladder broken? So we have to sometimes look at those things. So this is a slide that talks about health disparities, and they're driven by social and economic inequalities. So when you look at here, you have racism and discrimination. And I will tell you, you could put racism, you could put sexism, you could put classism, you could put ableism, you could put any kind of ism out here. And then you can then say discrimination. So if you look, remember, these are our social determinants of health. And so when we have those othering of other individuals, these are going to drive the disparities, and these are going to impact people's mental health and well-being, and impact the morbidity and mortality and expenditures, because we know that the system is not created equally and there's inequities. All right, and why do we care? So we say we spend a lot of money. We do. United States, great country. We are big baller shot callers when it comes to the amount of money we spend on healthcare. And is this slide surprising to anyone in the room? Nope. Does anybody know we spend a lot of money on healthcare? Yep, right. Okay, we spend a lot. Everybody said a lot of money, more than any, country. Yet, when you look at how we fare against equity, access, morbidity, mortality, we tend not to fare so well. I'm gonna show a few more slides. So this just looks like, and this is older data, but this is where United States works. And when you think of things like infant mortality, this is where United States is. And this is like New Hampshire. I think Mississippi is down here. This is Mexico, Colombia. These are fewer. This is where we find infant mortality, okay? In the United States, women of color, specifically Black women, specifically, and this is from the CDC, so they use the term here. This is an older slide. It's about 2 years old now, but the data still reigns true. Black women and Hispanic women. Black women, 3 times higher than maternal mortality as our white counterparts. We're more likely to die. And this is after you have controlled for education and socioeconomic status. So if you want to put a face to this, put Serena Williams, Beyonce, though people who can have the best of the best still are more likely to die from childbirth. So originally, a long time ago, was, Black women, maybe they just don't take care of themselves and things like that. But once you control for socioeconomic status and education, a lot of the thought is, and Arlene Geronimos has done a lot of this work, there's the weathering hypothesis, the proposed to explain premature decline of health in African-American women and women of color exposed to stress, dangerous environments. General social disadvantages are presumed to have cause an accelerated wear and tear, and even wear and tear on the telomeres. And I know this is a bit of an eye chart, but basically these are systemic inequalities leading to biological environmental interactions, physiologic adaptation. You have this allostatic load, cellular aging, and then impacts your health and life expectancy. All right. So I'm dropping a lot of stuff because I'm going to get somewhere with this soon. So the other thing is adverse childhood experiences. So now you're kind of hitting back to my territory with pediatrics and teenagers. So adverse childhood experiences, this is something we can screen for in kids, and we should be screening for. Most pediatricians are screening for this, where you're really screening for abuse, neglect, household dysfunction, physical, emotional, substance abuse. And actually, even if you have adults, there is an adult ACEs where you can screen for people if people have been exposed to ACEs in their childhood. And we know that the more ACEs you have, you are more likely to have poor coping mechanisms and do things like smoking, alcoholism, and drug use. You're more likely to have obesity, depression. You're more likely to have lower graduation rates, less likely to have you're more likely to have lower academic achievement. And so then think about that. You're more likely to have lower academic achievement. You're more likely to have lower wage, then lower paying job, working poor. All right. So then think about that. If I have all those lower socioeconomic status, disrupted neurodevelopment, more likely to have early death. And that's how ACEs and other factors impact. Right. I'm throwing a lot of information at you. I know. What's wrong with this picture? Someone besides the obvious. But anybody want to call out what's wrong with this picture? Water bottles outside. Okay. Anyone want to guess where this picture is from? It is not Flint, Michigan. Not Grand Rapids. All right. Everybody gets Flint. So it is actually from Benton Harbor. And it was about 3 or 4 years ago, Benton Harbor had a water crisis. They had high lead. And so I had a colleague who worked in Benton Harbor, and they were having issues with their water. And I said, well, how's Benton Harbor doing? They said, do they have water? And they said, yeah, they have plenty of access to water. People got water piled up outside their house. I said, really? And now, is it bad that you have water outside your house? No, because you need water. If anything, people always talk about they can't eat. You need water. We need water to live. But what has gotten to the point? Why did we get to the point that we need water? What happened to our infrastructure that we let it get downgraded to the point that we have to give people water? That is the problem. Those are the inequities we have. And is anybody here familiar with Benton Harbor, St. Joe? Anybody? I see a few hands. Have you ever know? You go over the bridge in St. Joe? That's I see some heads. For those online, I see some heads nodding. Inequity, you know, there's such an inequity in that community. So yes, so everybody guesses Flint. So those are inequities. And why do I bring this up? Because your zip code is the most important predictor of health and well-being. And we know that all zip codes are not created equally, right? All right, so, and I don't know if this is coming up for those of you in the audience, but for online, this little red square, and I could not find this for Holland. This is Grand Rapids, all right? You can go on after this, and you can go on to Not Even the Past, Richmond, Daddy, Vulnerable Legacy, and it really focuses on redlining, the history of redlining. We don't have time to go into that tonight. This little red box is where Dr. Lowery grew up. Here, the red box, and within the red box, your life expectancy is about 77 years. Really good, right? Pretty good. Y'all like 77 years? That's great. I am blessed to say that my father is, as he calls it, the double eight. And so, yay for him. So he's outlived his life expectancy. But that, praise the Lord. But anyway, if you go to East Grand Rapids over here, life expectancy is about 91. So this street is MLK, used to be Franklin Street. When I grew up, it was MLK. And so when you change, once you go about 5 blocks, it changes into East Grand Rapids, and the street is called San Loray. And I used to joke, like, I grew up on West San Loray. My dad was like, nah, you grew up on Franklin Street, baby. But anyway, 5 blocks makes a difference. Less than a mile makes a difference. 1 to 2 miles changes your life expectancy from about 77 to 91. Because what? Grand Rapids 49507 has a whole different tax revenue base in East Grand Rapids. Okay. And just to talk about lead, I'll go back to lead. 49507, 49506, 49503. We still in Grand Rapids have issues with lead, but it's in our paint, not in our water. And we still have, so we still aggressively screen for lead. And probably, I have a colleague who works in our grammar school systems, probably at least a couple times a year, one of their students has to get relocated because them or one of usually their little sibling, the baby gets tested for lead, and then all the siblings get tested and they have high lead. Okay, inequities. So let me bring it back to where we are. This is Ottawa County. I went online. I said, okay, I'm going to Ottawa County. I need to know a little bit about Ottawa County. Ottawa County is ranked among the best counties in Michigan and the nation for length of and quality of life. Ottawa County is placed among the best counties due to strong health and education, safety, and environmental factors. And I got this offline, and so I saw something that said it was ranked the best in the state, but then I pulled this directly from this report. So I'm gonna read this. On many levels, the finding of the 2023 Community Needs Assessment portray Ottawa County as the community that has slipped a bit from its former status as the most recent county rankings as the 3rd healthiest county in the state, still with 3 hospitals, free clinics, and hundreds of healthcare professionals. Healthcare is accessible to most in that if they can afford it or have high quality health insurance. What's wrong with that statement? Still, most. If, or. So there's health disparities, right? If I can afford it, or if I have high. So remember Pat and Sean, they're living in Ottawa? All right, Needs assessment. This is what Ottawa County said they needed: access to mental health, because some of the highest levels of psychological distress, anxiety, and depression recorded since 2011 in the county. Other things they want to tackle is physical health and chronic disease rate, addressing social determinants of health, substance use disorders, addressing health disparities, and continue to work on inclusivity. And so I pulled this from the ground up. Things they want to work on is to increase access to a patient-centered and community integrated system, increase access to patient-centered and community coordinated systems of care, and support working to improve housing access to underserved and vulnerable persons. And these are the objectives. So these are the things that Ottawa says, you know what, these are the things we need to work on. And so remember that I talked about downstream and upstream. Downstream, these are the individuals, what the patient sitting in front of you. How am I going to treat that patient? I need to ask why you're not taking your health, why you're not taking your blood pressure. I need to understand why you might not be able to see me. Can I make that appointment virtual versus having you come all the way in town? Understanding the healthcare costs. Midstream is when you're working with groups. You're working with nonprofits or other organizations and programs and understanding the resource allocation in your community. And then also looking upstream. And this is the hardest thing. And when we're talking to students and even residents, how do we understand inequities at these larger system base? And this is the isms. And these are really the things that are really hard, because you're like, I'm just one person. I can't fix all of this. I don't know how to fix all these policies. I'm not a politician. I don't know how to fix it. And so that's where a lot of time it gets really overwhelming, because you're like, well, I don't know where to start. So why do we have to start somewhere? Addressing disparities in healthcare is important from an equity standpoint, because improving the nation's overall health and economic improving the nation's, it will improve the nation's overall health and economic prosperity, right? If I have a healthier community, if I have healthier patients, it improves everyone's health. It's the right thing to do, duh, right? We went into healthcare because do no harm. If you go to medical school, when you graduate, you take something called Hippocratic Oath. One of the things is do no harm, but it makes our patients feel better, right? I don't think anyone went to medical school or going to be a healthcare provider because I want to do harm, right? And if you go into that, then we have a whole nother conversation. That's something else we got to talk about. But we want to help our patients, right? Disparities are costly, resulting in access medical care costs, loss of productivity, as well as additional economic losses due to premature deaths, right? If I can help someone have a healthy pregnancy, if I can help someone not have a premature infant, if I can help someone manage their diabetes better, that will be a more functional person. If I can help them with their mental health, those things, they could go to work. They can be a healthy adult. That's my goal. So now what? A lot, right? What we gonna do? Right? Okay, this is sometimes like, can somebody else do this? This is a lot. Can I just take a nap, eat a donut? I don't know. What can we do? And it's okay to feel overwhelmed, all right? We haven't figured it out yet, bit by bit. So if you never, there's a part, I think I say where you fit in. This is what, get in where you fit in. It's bit by bit, right? So, and this is not new. This is like 200 years ago. Medicine, if we're to fulfill her great task, then she must enter the political and social realm. Do we not always find diseases of the populace traceable to defects in society, right? We have to do this. And sometimes it's at the individual level. Yes, we might want to do big and grand things, and I'll show you an example of that, but I'm also going to show you later on some examples of some little things that we can do, that you can do. So, things that we can do. And I know, like, these are things we can talk about our biases. And one of the things is I do bias training, but everybody like, well, we all have bias. I have bias, you have bias, everybody have bias. When people like, I don't have bias, yeah, you do. Okay, we all do, all right? But why? We know that if we talk about it, if we work on it, it improves real clinical behavior, right? If we just slow down. There's even been studies, if you sit down in the room right? I'm not gonna sit down right now because I'll fall, and that was a bad imitation of somebody sitting down. But if you just sit down, talk to people. And let me tell you this, I've been doing this a little while. I get it wrong, right? Because a lot of times we're rushing around, I'm teaching, I'm trying to do, sometimes you just have to slow down and just sit, right? Counter stereotypical mental exercises, mindfulness, intention, things to be, what can we do differently? Sometimes just asking the patient, what are you worried about? When you leave here, what are you going to do sleep about? I found that very helpful because sometimes something they're worrying about. And this is the other thing, and I'm going to say this is not part of my talk originally. Chat GPT, AI, people have looked it up already. So they've made the diagnosis. So, and Dr. Google. So really, they'd be like, well, I've chat GPT'd it. And they told me, and I always say, well, did they tell you was this? Yeah. Okay, it's not that. Okay, it's just, okay, trust. And that is the other thing. As much as I love being a doctor, there's a lot of things in medicine. People don't trust us like we do. Well, you didn't say this, chat GPT told me that. So talking to your patient. Building a more diverse and culturally competent workforce, hiring, promoting clinicians who reflect the communities that we serve. And that is a big passion of mine. I've been around, people say, well, Dr. Lowery, what keeps you in the community? One, I love my community, but I also, one of my passions is how do we continue to promote and get people that look like the communities we serve? And if they're don't look like, then promoting people who say, I want to listen. This is a welcoming community. Support interpretive services and language appropriate materials. Expanding training, but training is not enough. We need to make it and pair it so that people feel that they have the tools to make people feel welcome. One of the best things we have in our office, and I take no credit for this, we have a sign when you walk in the door. And my front desk staff bought this. She has all these nice things up. And it says, everyone is welcome here. Beautiful sign, cute little sign, colorful. Been there. I've seen people take pictures by the sign. I'm like, that's a thing. They're like people, family members, people doing selfies by it. That's nice. Make people feel welcome. Strengthen community partnership. Co-create programs with community members. Use local data to identify disparities in the neighborhood and population. And this don't mean everybody gotta go create another nonprofit. That's the other thing. I love nonprofits, but everybody sometimes I'm like, I be at something, but work with nonprofits, prioritize conditions with the greatest inequities in your local population. What does your community need? And I think the biggest thing we need to do is talk to the communities, and that you have to build community trust. Addressing social determinants in healthcare settings. Screen for social determinants of health. We have a form that people filled out. We ask. Partner with insurance and community organizations to support patients. Advocate for system level reforms to incentivize social determinants of health interventions. What do we need to do to make it easier for our patients? And the system is unwieldy. Our medical system, raise your hand if you've tried to use our medical system and it's kind of complicated, right? It is kind of complicated, right? I had an issue one time, like about a year and a half ago. They called me 3 times trying to schedule a test that I'd already had. And I was like, I've had this test. It's complicated. Advocate for policy and systems reform, whether it's Medicaid or other expansions, and then accountability for monitoring equitable intervention. So I wanted to put this out here. I don't know if you can, let me go back. This is RX Kids. This is program been out, I think about 2 years now. Dr. Shameless plug, Dr. Mona Atisha, CHM alum, graduated from our medical school. If you haven't heard, she's the person who was famous for the Flint lead crisis, pediatrician, identified that, has got with philanthropy and grant work. This is a program that actually gives pregnant moms and babies like $1,500 and possibly $500, like a cash stipend, and helps them during pregnancy in the first year of life. You can just Google it and hear about it. It's in probably now, I'm thinking about 19 communities, and it's the data that's out is showing it's really helping close the gap. And the parents can use it for what they need it for. And so that's a way you know, and Mona, every time I'm like, wow, like she's like a person, I'm like, wow, you're kind of amazing. You see, when do you sleep? Or you can do something like this. So not all of us can be Mona or Tisha. Okay. And this you can't see. And this is I should have taken, I didn't get a chance to take a picture today because I had already put in. This is a pantry we have at our store, not our store, at our office. We used to in our practice be able to give out gift cards to our patients. So they come in, need a gas card, they're just low on funds. We could give them out a gift card, no questions asked. And for some reason, our institution kind of started saying, well, we don't want to give you to give out gift cards. So my PA, a Hope alum, I will say, I shout out to my PA, Jill Tallman. She said, you know, we can't give out gift cards. We need to do a pantry. I said, cool. And I said, well, I'll write. She said, no, you got enough going on. I'll write the grant. So last year she wrote a grant, and I take no onus. And this is actually not stocked. They literally restocked it today. Our stock was a little short because of the bad weather, but this is unstocked. And so basically, you can come when we see you, you come in. There is a laminated form that patients can just circle, and this is what I need. And then the MA looks at it, fills it up, and you leave with a bag. And so we have food, we have, you can't see it over there. There's like different toiletries. So it's kind of like office shipped. You know, they come in, they leave. The flip side of it is we've actually had some parents and some families say, how do I donate? How can I give back to your clinic and give money so you can fund your pantry? And so that's the way. So you can be Mona Atisha, or you can be the next Jill Tallman and Monse and Evelyn and Carrie. Those are my shout out to my staff, because Jill wrote the grant and the team wrote the grant, and they have taken it on and taken it up to a level, because they were like, we don't want patients to feel like they're on the spot and got to come back. And they've taken ownership of it. And it's a beautiful thing. And we've serviced over 140 families since August. So shout out to them. So those are the things you need to do. So where do you start? Get in where you fit in. And I know it can be overwhelming. I'm overwhelmed, and I've been doing this almost 20 years now. You know, this is a slide that I adapted talking about microaggressions, but I thought about it. It's really good. Where do I get in? Sometimes I can feel so overwhelmed. Well, I can get in at a leadership level. I can get in intentionally diversifying my experiences, interacting, coming to things like this. I can get in, coming in with cultural humility and curiosity, just learning about something, just listening to the patient. And I have to remind myself of these things. Questioning, coming in with curiosity, self-reflection on my personal biases. And this is a circle, because you kind of always got to do this. And sometimes you could, and what I'm proud of, we thought about like, how do we, back to our little pantry, we thought, okay, how do we get gift cards? And we couldn't figure that out. But you can get in and do things like that. You can get in, be involved in nonprofits, or you're servicing your community. That's how you can get in and learning, talking to patients. So again, sometimes it can be overwhelming. You don't know where to start. I always say keeping it simple. Keeping it simple. You know, one of the things, and as we were talking to some students overall earlier this evening, sometimes you want to do so much. Sometimes keeping it simple, just the little things help. So keeping it simple, finding out one or two things where you can be impactful. And I've learned something today, and I'm always reminded of this. Continue to stop, pause, and listen to your patients. I learned that even last week, a patient I've been taking care of for now 13 years. I learned something new about her that I had not learned about her. Like, I was like, oh, I didn't know that. Oh, I didn't know that. Now, I didn't do that face. I was like, oh, really? Oh my gosh. I had my caring voice and my doctor voice, but stop and pause. And she came in for A and went to B. And part of the visit, she just sat and cried. And I let her just sit and cry for 5 minutes because it was important. And I learned probably some things. And this is a patient I see probably every couple of months, maybe once a month. And I've been taking care of for 13 years. And I learned two things about her. So it's important, keeping it simple. So equity asks what? Who's in the room? Who's not in the room? Can we get that person in the room? A lot of times we pause and, well, we can't get any. Well, why can't we get any? We can't get this person. Can we get that person? Now that's not even an excuse, because we can Zoom people from across the world. Now they can be in the room if they can be in the room virtually, and have everybody's voice been heard. And that's one of the things, like I said, I'll go back to even our little pantry. My team has taken that above. They were like, I got to. I mean, they've taken it over because their voices have been heard. Our patients' voices have been heard. And making sure, and we continue to listen to your patient, listen to people. My grandmother, this is in part of my talk, but I'm gonna pause and say this. My grandmother used to tell me, and I don't come from a family of physicians. She would always say, somebody can tell you to always teach you something. So one of the greatest things you can do is learn from your patients. All right. So get in where you fit in and keep it simple. Health equity, you want to be explicit. You want to adopt a health in all policies approach. Where do we remember at the end? It's about that patient. It's about always keeping Sean and Pat in my mind. So yes, I'm going to work equally hard for Sean, who has Medicaid, and Pat, who has whatever HMO. And you know what? I've learned and developed a network that I know in a few workarounds that I can hopefully get Sean the same services that I'm going to get Pat. And that's when you develop a network. Those are the things. Create an internal organization, a wide culture of equity. Respect and involve communities in health equity initiatives. If you're going into communities, talk to the people and involve those communities. Please stop telling us we have health disparities and we just got to do something about it because we know we have them, right? Measure and evaluate progress in reducing health disparities, but let's not just get focused on the measuring, and let's get to doing something about it. So I got about 3 more slides, and if you ever hear me talk, you're probably gonna, if you hear me talk like 1 to 2 years from now, you're probably, and if I'm talking on some similar talk, you're gonna hear these 3 slides because these are what the things I'm gonna say. There is a lot of work to be done. Still a lot of work to be done. And the work begins with your sphere. We cannot hide. We cannot be afraid. Change does not happen overnight. Change is slow and steady, and change can be scary. And sometimes I feel like change, as I've been doing this a while, sometimes I feel like I'm changing and then I'm pulling back and I'm changing, I'm pulling back, but you still have to stay steady in the boat. But if we work together, we can push this big boulder up the hill. The work starts with us being brave, being humble, being intentional, and being dedicated. And lastly, taking care of yourself. While this work is inspiring, it can be exhausting. So taking the time and taking care of yourself. And lastly, not everything that is faced can be changed, but nothing can be changed until it is faced. And so we can't hide from it. We have to face it. Patients don't care how much you know, but we want to treat them the way they want to be treated. And I thank you for your time and your attention. Or did I scare y'all out of medicine? Yes, question. Mm-hmm. 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 Very good question. I'm repeating for those online. So the question was, for example, when I will say things like Medicaid expansion, it's such a big issue, then you going outside your circle. And sometimes that's when a time I would say your circle becomes a area of advocacy. So how can you be an advocate? And so that's where your circle is not, it's just bigger. So, and I will just say from my lens. So, as when you get into, AAP, American Academy of Pediatrics, Society for Adolescent Medicine, if you're a family medicine physician, emergency medicine physician, we all have these societies that we belong to. Those are ways to advocate. If you are a registered voter, okay, even if you don't live in Ottawa County, you're probably a registered voter. If you're here from Colorado, I'll make it up. You can write a letter. Dear Congressperson, I am a registered voter in X, Y, and Z. This is why I'm not concerned, right? And that's where your circle gets bigger. And so your circle, you're on this college campus, right? That's why your circle. So a lot of people think your circle is just your short sphere people. That's where you're involved in all these different organizations. And so that's where you look, how can I advocate for things like that? How can I amplify my voice? Very good question. And there's a lot of ways to advocate. And so, and that's one of the great things about being this, from American, the AMA, there's a lot of different societies that you can be involved in, and they will actually talk you through how to advocate. Yeah. Other questions? Yes. Yeah. So the question was, my roles in the community, how has that impacted? Give me the question one more time. I got to rephrase it. Yeah. Yeah. How has I used my role as a physician to impact my roles in community? Yeah. So this is the thing. People want to hear your stance on things. So I've been involved in Kent County Health Department advocacy. I'm involved in a lot of health advocacy groups like Grand Rapids African American Health Institute. So I could probably be on way more boards than I want to be. I think it's important to have a voice at the table. This is my thing, though. Right now, I'm on a Grand Rapids Public School Foundation board. Before I get on the board, I also don't feel like it's just great to be on the board to be on the board. Oh, I'm on board. That's not. I actually, when someone asks me, I ask first couple things I do is, when do you meet? And I like to know what the board is about. But I really think it has allowed me to, one, give back to the community, because one of the things I said when I wanted to grow up, I wanted to grow up and be a doctor to take care of my community, and that allows me to give back to the community. I'm on some organizations, or I have been on some organizations that gave me scholarships to go to school, and so I feel like that was a way for me to give back. But I do think it's a great way to have a lens, to say, what, as a physician, these are the things I think we should do. And so as a person who's from the community, these are the things I think we should do. And so I think that's what's important. And I do think people look to you as a leader. And so, but I think before you start being on any kind of board or being involved, those are kind of the things that, from my lens, that's what I decide to do before I start to be on any board. Other questions? And obviously, and if they align with my views, and so I have very broad, very broad views. And so I'm like, I bring myself to every board. So I'm like, you need to know I'm on this board, and you need to know I'm on this board. Do you have a problem with that? And they're like, no. Okay, cool. Other questions? Yes. What ways would I would love to see the medical community increase their cultural competency? Very good question. Wow. How much time do you have? No, I really, Wow. Who? Where do I start? That's a very little. There is so much. How do I want to say? I think we need to do better with our unhoused group. We need to do better with people that have substance use disorder and understanding why. We need to do better with people who have mental illness and understanding why. We just don't have patience. We need to do better with people who English is not their first language and understand. So, and a lot of it, and I am not giving us a pass on this. Okay, I'm not giving this us as a health community. A lot of times, so there's, if you've heard, you walk into a room and within like 11 seconds or 8, I think it's 8, you've made a decision, snap decision on who people are. Those are biases. But in medicine, you have to make snap decisions, right? And I'm not talking about the ER decision, the person's bleeding out. I'm not talking about that. I'm not, I'm not caring about like, how are you feeling if you're bleeding out? I'm really talking about you're going in the room and talking to people. We don't allow enough time to unfold, right? And in medicine, it's like, I got to get in and I got to get out. And we need to sometimes just slow down. And that's where our bias is. And so I think that's where, if I could change those 4 things: our unhoused, mental health, our patients who English is not their first language, mental health, our gender diverse community. There's so many communities. I just think we just need to like understand people more. But I think that is being comfortable with asking the uncomfortable questions. Okay.
And I realized something. Dr. Lowery has a great distinction now as a Your Health Lecture Series speaker. She's the first to complete the Calvin Hope series. So she's spoken both at Calvin and Hope now. So that's great.
You know what? I work with somebody who works. I work with one person who works with help at Hope, and one person works at Calvin. So now you know.
All right. Thank you, Emily and Terry, for hosting, and Hope College for hosting us. And have a great night. Be safe. Thanks.